Hello guys, hope I am audible and visible. A very good evening everyone. Okay, great. So today we'll be going towards one more session of a few MCQs. We'll be discussing the same thing what we've been doing for the past couple of days. And we'll be adding a few more sessions. Maybe if it's going to help you, we'll be having a couple of more sessions on YouTube, if possible on a Sunday, so that we can learn more, right? So yesterday we had a few questions and also we discussed about osmotic fragilities in the end. Today I wanted to take about okay, thank you Deklinga. Today we want to take about neoplasia as such, because neoplasia is an important topic and we are going to discuss a few questions based on neoplasias and I want you guys to answer. So once you give a right answer, hopefully if it is right, and we'll discuss. If it is wrong, we're going to learn through it, fine? And few updates before that, and I hope all of you will clear the exam and come as a topper soon. And these are the free tests for this week. Please use it judicially. Whichever topic is difficult for you, if you have a free test there, use it judicially. And I would say preferably attend in a laptop rather than a mobile phone. A bigger screen, it'll look like a simulation of a real exam, fine? And if you're an Iconic or Plus subscription, you'll have a combination of both Preplat and Unacademy. And we have daily at 7 p.m. special classes. Today at 7 p.m. we'll be discussing about liver images from Robbins. We are going through a series of image discussion on Robbins, and I hope that will be helpful for your upcoming NEET and INSTT exam as well, fine? And there are a few batches. If you want to enroll, if you are into any of this FMG or your INSTT or your NEET PG, do enroll to it, fine? And your INSTT schedule is also out. The 8th May will be the next INSET exam. So let's see, after NEET you will have a couple of more months to concentrate on INSTT. I would say that if you are preparing for this NEET, just a couple of more months, hold it there and hit the INSET exam also in full force. So if you have been preparing consistently, that will definitely help you in securing a good rank there as well, fine? Okay, so let's start. I'm going to show you a few images, few MCQs. I want you to answer the MCQ first. So I'll give, let's say, 35 to 40 seconds for this MCQ. Do comment on the answer. So once you comment on the answer, let's go ahead and see how to rule that out or how to know the correct answer, fine? The time starts now. Declan has gone to with C. Okay, anyone else wants to add to it? Again, C. Okay, Akshit has gone with B. Anyone else wants to add any more answers? It's fine if you're wrong. We're going to learn from the questions, that's all, fine? I'll read through the question first. It's a 55-year-old woman present with an increase in weight loss and fatigue and subsequently dies on metastatic cancer, right? This is one of the important clues for me. So I'm dealing about something of a metastatic cancer and you have a vertebral column at autopsy, right? Okay, Joe has gone for A. Let's see. So I'm having a vertebral column with lesions here. If you can look at the lesions, these are the blackish lesion. So when you see a blackish lesion in a vertebral column, see, this is an autopsy finding. So this could very well be blood as well, because in condensed dark blood hemorrhagic areas can also look blackish or brownish on a gross morphology. But it's too blackish for me. At least in the first look here, right? And the patient is having a metastatic cancer. I'll go with whatever Rijo said first, multiple myeloma. See, if it is a case of a multiple myeloma, this lesion in the vertebra, will I call it metastasis or not? Or is it just the primary lesion? A multiple myeloma vertebral lesion is not metastatic, right? So if it's multiple myeloma, it's not going to be a metastatic lesion, it's a primary lesion. So I'm going to rule out multiple myeloma. Multiple myeloma also have punched out lesions. Again, it will be hemorrhagic mostly, reddish to brownish color. It will not be blackish in color, fine? We'll go to chondrosarcoma. Two of you went for chondrosarcoma, right? So first and the foremost thing for me for chondrosarcoma, the age is definitely there. 55-year-old will be most likely for a chondrosarcoma. Chondrosarcoma, you must have seen your tumor on the gross, right? You must have seen cartilage in the gross in naked eye. What do you think will be the color of cartilage? Will be whitish or blackish? You must have seen cartilage in your anatomy dissection in the cadaveric images or in exostosis. The color of the cartilage is generally glistening white in color, right? So a chondrosarcoma which arises from a cartilage will also have the same glistening white appearance. It will not going to be black in appearance, right? So it's not chondrosarcoma as well. Again, osteosarcoma also you must have seen, it will be whitish. It's most of the bone forming lesion will be whitish with slight bit of hemorrhage. It's not going to be black in color, right? So the color wise, one which fits in is your melanoma. It's black color, that's also melanoma. Melanoma in a vertebral column is undoubtedly metastatic. So everything what fits into this diagnosis is melanoma, right? It's a metastatic melanoma from the vertebral column. Again, don't go with one finding alone. When you go only with the punched out like lesion in the vertebra, you might mistake it for a multiple myeloma. The question says it's a metastatic cancer, so I'm going to settle for a melanoma, fine. So if it is not a neoplastic lesion, can any one of you name any one non-neoplastic lesion which can cause black deposits in the vertebra or in the intervertebral disc or somewhere? Any non-metastatic, non-malignant, non-neoplastic lesion? Anyone? Anyone? Excuse me, sorry. Ochronosis, right? Your ochronosis can cause cartilaginous blackish deposits, vertebral blackish deposits in the earlobe. It can also cause in your vertebral lesions as well. Fine, perfect, right? Great. So since we are in the topic of metastasis, I'm just going to ask you a few classical questions in metastasis. Hope you'll be able to answer it. Fine. Let's say that you have an lesion in the lung, liver, brain, heart. In all these conditions, which is the most common tumor, primary or metastasis? We have lesions in the lung, lesions in the liver, lesions in the brain, as well as lesions in the heart. In all these four organs, the most common lesion is metastasis, is more common than primary, right? That's the first thing for me. In all of them, mets are more common than primary. So if you have a blanket statement of the most common tumor in any of these organs, it's going to be metastasis coming from some other different organ, right? Second thing, I have all these organs named, right? Lung, liver, brain, or your heart. In all these organs, mets will be seen in the center of the organ or in the periphery of the organ. I didn't go with adrenal for the only reason it's a very, very rare lesion. So we'll ignore adrenal, and once it becomes very rare, the incidence totally depends on the study what I'm doing. Fine. In all the organs, mets location will always be in the periphery of the organ. So what do we mean by peripheries? If it's a pleural, if it's a lung, it will be close to the pleura. If it is a brain, it will be close to my cerebral hemisphere. If it's heart, it's going to be close to your pericardial lesion, close to that. Same thing for my liver as well, close to capsule, right? Second thing, mets in an organ will be single lesion or multiple lesion. That's also very classical for metastasis. Metastasis will be single or multiple. In almost every organ, mets has to be multiple only, right? It will always be multiple. It cannot be single. That again takes to my image. I'm having multiple lesions, right? It's almost always multiple lesions. One of the thought process in any organ is going to be metastasis. Fine. Okay, third thing, mets generally will be well-defined lesion or an ill-defined lesion, because these three are very, very characteristic for metastasis: well-defined or ill-defined. Mets generally will be an well-defined lesion. Keep this in mind, because why this becomes important for me is, one, for a practical application for me. At the same time, in an exam also I might solve few questions based on that. When I take in malignancy per se, a primary malignancy, let's say there's a lung, and I'm going to have a malignant lung lesion, or let's say squamous or an adenocarcinoma, it will be ill-defined like this, right? If it's a malignancy, generally I'll think of an ill-defined lesion. That's what I'll generally think of any malignancy. But the same malignancy, with the same lung cancer, let's say it assumes it's spreads to liver. In liver, it will form well-defined lesion. I'll go up, maybe I'll erase this, whatever marking I have drawn. Most of the thing here, it looks well-defined, right? It's not infiltrating. When I say it's ill-defined, it'll have tongues like this. It's not infiltrating like this. All the lesions here are defined. They are not capsulated, they are defined, right? They're definitely well-defined here. Mets always will be well-defined, keep that in mind. Generally, when I say cancer, we go for ill-defined lesion, mets will be well-defined. You know the answer already in the form of an MCQ. It's important because sometimes the application might miss it if I don't know this concept behind it. Fine. A lung cancer secondary in a radiological chest X-ray finding, what is the classical finding named as? In lung cancer, secondaries in the lung, what's the finding? We call them as cannonball lesion, right? You must have heard this for sure. Cannonball or your coin lesions, that's secondaries. Again, cannonball, it's a defined thing, right? When I say ball, it is defined, it cannot be ill-defined, right? So almost every secondary, be it lung, liver or brain or heart, will be a well-defined finding only. When you go and sit in as an intern or a first year PG, you see multiple peripheral nodules which are well-defined. Please think of metastasis. I am not saying always it will be metastasis. That's one of the findings. It could be metastasis. I should not miss the findings, right? These are common for metastasis. Next for me, when I take metastasis, the roots of metastasis, there are very, very classical roots of metastasis, right? First, let's take your carcinomas. Again, these are very, very important basics. I'm sure you know this, right? What is the route of spread for carcinoma? Hematogenous or lymphatic? Carcinoma generally prefers one route. Sarcoma prefers the other route. Carcinoma generally prefers lymphatic spread, right? And sarcoma generally prefers hematogenous spread, right? So sarcoma generally prefers an hematogenous spread and carcinoma prefers lymphatics. Doesn't mean that a carcinoma will not spread via your blood circulation. It will. And a sarcoma will also involve lymphatic spread. But in general, carcinoma prefers lymphatics and sarcoma prefers hematogenous. Again, there's a very simple thing. All of you must have done this in your final year MBBS. When you take a surgery case of breast cancer, you must have examined. The first thing immediately what you look for is axillary lymph node. It's a breast carcinoma will undoubtedly first thing to be involved is axillary lymph node. I don't go and auscultate a lung always, but always I look for axillary lymph node because that's a preferred route of metastasis, fine? Okay. Again, there are few exceptions. I'm sure you know the exceptions. We'll talk about only one exception and then we'll go to the next question. There's one tumor, one malignant tumor, which does not undergo metastasis. What tumor is that? That's a very classical tumor. Which tumor doesn't undergo metastasis? Malignancy, which doesn't undergo metastasis. BCC is one, other one is glioma, right? These are two things which rarely spreads or doesn't undergo metastasis also. This I'm sure you must have seen many PYQs. Don't forget this, fine? Okay, great. We go next question. Same, we'll have an 30 second or 45 seconds gap. I want you to comment on the answer. Then we'll see what does the right answer. Answers? It's fine if you're wrong, but I just want answers from you. Deklinga carcinoid will definitely undergo metastasis. It's a low-grade malignancy, but they do spread. Any comments? Okay, Rijo started with D. Again, D. Okay, D. Fine, I don't know why there's a predilection towards D. We'll read the question and see what's the answer. It's a 46-year-old person presenting to the family physician with complaints of headache. Okay. And he has seizure and subsequently taken to the radiology for CT scan. There's a mass in the corpus callosum. The biopsy of the mass showed malignant lymphocytes, right? So tell me what is the primary diagnosis here? See, if I know the diagnosis, I can easily know what is the answer. What do you think is the primary diagnosis here? It's a case of an primary CNS lymphoma, right? When I say malignant lymphocytes, I'm going to think of a lymphoma. Now I've kind of made the question a bit easier. Now tell me if you want to change the answer. All of you answered D. CNS lymphoma is most commonly seen with which infection? If I'm going to rephrase that, what will be answer? CNS lymphoma will most commonly be seen with HIV infection, right? I'm sure you know this statement. It's HIV infection, right? So again, I don't know why initially you answered D. You know the subject, but still you made it wrong. If you know the subject and if you made it wrong, please retrospectively go and see why you made the mistake, so that you don't repeat the same type of mistakes again in your exam or in further questions, fine? HSV encephalitis is, it has a classical presentation, it has a classical lobe involvement as well, right? HSV involves which lobes? Which lobe of the brain? It will generally involve your temporal region, right? Okay, it involves the temporal region, and hemorrhagic encephalitis, hemorrhage in the temporal region, uncussed location. I'm going to think of an HSV encephalitis. HSV, herpes simplex virus, is not going to cause a CNS lymphoma. That's not the right answer, right? Hashimoto's, will it predispose to lymphoma? Yes or no? Right? Hashimoto, yes, it will predispose to lymphoma, but it's going to be involving only thyroid lesion. Hashimoto is not going to increase the risk of CNS lymphoma, but yes, it will definitely increase the risk of thyroid lymphoma. Fine. Hepatitis C infection and cirrhosis of the liver, that will not predispose to lymphoma, it will predispose to hepatocellular carcinoma. Fine. It's just going to predispose to hepatocellular carcinoma. Obviously, it's not going to predispose to lymphoma. Fine. Great. I'm not going to much discuss about it. Primary CNS lymphoma, one of the important thing I want you to rule out is HIV. See, there are few things, especially in hematolymphoid malignancies. If you see a primary CNS lymphoma, that's one thing I want you to think of HIV. This is a practical point of view. In future, if you see any of these cases, please rule out retropositivity in that patient. Fine. Second, there's a lymphoma called as plasmablastic lymphoma. Again, for plasmablastic lymphoma, I have to look at the hematolymphoid profile because almost every case of plasmablastic lymphoma will be associated with retropositive infections only. Fine. Again, I have a lymphoma called as a primary effusion lymphoma. See, all these are lymphomas which are very, very characteristically seen in HIV infected persons, right? So you should be able to remember this. If these three comes in your real life practice, please investigate for retropositivity. There are many other lymphomas which can also be predisposed, but these three are like a classical feature seen in HIV positive individuals. Fine. Okay. Let's go to the next question. It's a simple question, but please read the question carefully and see what the question is asking and then comment on the answer. Fine. 30 seconds again. It's fine if you're wrong, but I want you to comment the answer. Okay, we have had different answers, D, C, as well as cytology, right? Rest, I want every one of you to answer something. If you're wrong, it's completely fine. Okay, we'll read through the question. Okay, B, D, okay, fine. It's a 59-year-old person. Noticed blood in the urine in the past week. Fine. Cystoscopy shows a 4 cm exophatic mass and the biopsy has been taken. After biopsy, he undergoes a radical cystectomy, right? The specimen shows an anaplastic carcinoma. When I say it's anaplastic, I really don't know the origin. It's very poorly differentiated. That's what I mean by anaplastic lesion, right? Which is infiltrating the bladder wall. So I definitely know it's a malignancy. When it's anaplastic, I will not be able to say what type of malignancy it is. Is it squamous or transitional or adeno? I won't be able to know, right? So the question is simple. Which of the following techniques applied to the cells in the neoplasm will help me categorize the cell of origin? Since it's anaplastic, poorly differentiated on a microscopy, my H&E alone is not enough for me to tell what is the cell of origin, right? So I need to know the cell of origin. We'll take most of the answers, right? We'll take one by one. Can karyotyping tell me what is the cell of origin? In general, none of you answered karyotyping. Obviously, karyotyping will not tell me the cell of origin. The only thing it can tell me is, okay, this is the chromosomal abnormality there in the cancer. It will not tell me this chromosomal abnormality is arising from skin or arising from my glands. It cannot tell me, obviously, right? Cytology. By looking at a cytology smear, can I tell this is most likely adenocarcinoma? In a cytological smear, if there is pigment, can I say it is melanoma? I can tell to some extent, right? So cytology smear can help me to tell it is originating from this particular cell. Like when you see OR rods in a cytological bone marrow aspirate, what will you think of? When you see OR rods, can you say that it is arising from myeloid lineage, myeloid leukemias? You can say that, right? Perfect. But that is not the answer here. Why I'm saying it is not the answer here is, you can also tell it's squamous cell carcinoma, right? Why I'm saying it's not the answer here is, the question clearly says it's an anaplastic lesion. So in cytology also, it's going to be very, very poorly differentiated. When it's poorly differentiated on a biopsy, When it's poorly differentiated on a cytology also, I cannot really say what is the origin, right? In a normal condition, if it's a well differentiated tumor, yes, I can say it's transitional cell carcinoma on a cytology. But in this question, since it's anaplastic, it's not the answer. Come to option C, flow cytometry, right? So flow cytometry, will it help me to tell it's an B cell lymphoma or a T cell lymphoma? Can I say the cell of origin based on a flow cytometry? Yes. I can even say AML M1 or M2, different types of AML, right? BALL, TALL, AML, ALL, everything, right? Flow cytometry also will help me to determine the cell of origin. But unfortunately, will flow cytometry be useful for a bladder neoplasm? It will not be, right? This is useful for hematological neoplasm. If I have an hematolymphoid malignancy, if it's a lymphoma or a leukemia, my flow cytometry will help me for the cell of origin, fine? But obviously not for a bladder condition, not for a solid neoplasm. For lung, it will not help. For stomach, it will not help. Hematolymphoid, it will help. The only thing which I'm going to rely on is immunohistochemistry. Obviously, IHC is one thing which helps me to determine the cell of origin. That is the basic role of IHC. Actually, IHC has two roles. I'll talk quickly about IHC soon, right? One of the important roles is to know the cell of origin. IHC is very, very important for determining the unknown primary, right? So if you see something saying GATA3, if GATA3 is positive, it means I'm talking about a transitional cell carcinoma. Okay. Maybe the IHC which will be required for this is transitional GATA3. If GATA3 is positive, I know that the tumor is coming from bladder. If it is squamous cell carcinoma, we already know it's P40 or P63. If these two are positive, I'll say it's in squamous cell carcinoma, right? That's how I'll tell you the cell of origin here, fine? So let's have a quick look about IHC, because we have not spent much time to see how an IHC is going to be done. We know how to interpret it, but generally we don't know how an IHC is done, right? We'll just go through the basics of it. I'm sure all of you must have read about ELISA technique. You must have seen ELISA techniques. Obviously you must have, right? So my IHC is also kind of the same principle of ELISA, right? CK720 also might help for sure, fine? So when I say I'm going to have a cell here, the commonest done IHC which will come to your mind is your, let me take CK720 like Deklinga said, right? I'm just going to take your CK720. CK7 and CK20 are surface antigens, right? Let's assume this is a cell, and let's assume that this cell is CK7, the cytokeratin 7 is present in the cell, fine? At the same time, again, I'm having cytokeratin 7 in the cell. So what I'm going to do is, for both these cells, I'm going to do in one, I'm going to do a test of IHC of cytokeratin 7 here. In other one, I'm going to do a test of cytokeratin 20 here, right? So when I order cytokeratin 7 or when I order cytokeratin 20, what I'm going to do in the lab is, I will have antibodies. So in lab, what I do is, I'm going to add antibodies to cytokeratin 7. And here I'll have antibodies to cytokeratin 20. Because I'm doing cytokeratin 20, I'll add antibodies to that, fine? Let's assume in the first test, and the cytokeratin 7 is already present. So will this bind to it? Yes or no? It will bind to it, but here there is no cytokeratin 20. So will this bind to it? It will not, right? Here there is no binding, but fortunately here, since the cell has cytokeratin 7 antigen, and I am adding antibodies to cytokeratin 7, it will bind, right? So after this, the second step, what I'm going to do is, I'm going to add like a Coombs reagent. You must have read about Coombs reagent. It's an antibody to human immunoglobulin, right? So what I had here is, I'm going to add antibodies to human immunoglobulin, or just antibodies to immunoglobulin with a color called as DAB. Once a question came, what gives the color to the immunohistochemistry? The color is DAB, which is diaminobenzene. This is the coloring agent which gives a brown color. Okay, so once I add this, in the first reaction, I'm having an antigen in the cell to which I have an antibody. Will this structure bind to that antibody? It will, right? So it's going to be like this. Let's assume this is a cell of cytokeratin 7. My antibody was that. This is the antibody to cytokeratin 7, the first step. The second step will have antibodies to human immunoglobulin with the color of a brown color. I don't have a brown color, so I'm using a blue color, right? This is the DAP. So the second condition, second thing, will the antibody bind? It will not, because there's no counter staining there, right? So this is a simple principle of an IHC. So interpreting an IHC is a very, very simple one. If it is positive in color, it has to be brown in a microscopy. If it is negative, It's not brown in color. It can be anything. If it's not brown in color, I'm going to call it a negative, fine. It's simple like an ELISA procedure. I just sandwich it and I will do it here, fine. Tell me only one thing. Let's see if you can answer this question. Might be a bit difficult, but I'm sure you know this. Most of the time, positivity means something, right? For example, if I say a tumor is CK20 positive, I will tell it is from a lower GIT. Or if it's an ER positive, I'll tell it's from breast cancer. CK positive, carcinomas. Vimentin positive, sarcomas. Can any one of you answer? There's one IHC where negativity is important. If this IHC is negative, it makes more sense for me. What IHC is that? There are quite a few, at least one I want you to answer. Which IHC when it is negative makes sense? Negative IHC makes sense in quite a few, at least name one. Or in other words, a loss of a protein is very, very important for diagnosis of a lesion. Which loss of protein? Okay, I'll give you a clue. This tumor has Indian file pattern. Okay. They Clink are very good. That is a bit of a too hi-fi thing. I'll not go into it much. I'll tell you also why I won't go into it much. The easiest one for me is E-cadherin, right? So I'm going with E-cadherin. If E-cadherin is negative, my diagnosis lobular carcinoma. Because if you remember lobular carcinoma of breast, in lobular carcinoma of breast, if you remember, loss of E-cadherin causes lobular carcinoma. In other words, if E-cadherin is positive, it is not lost, it is not lobular carcinoma, right? So it's going to be very helpful. The negativity will be of helpful, right? Like whatever said Clink, it's also useful. The reason why I don't want to dwell into hepatic adenoma is there are many students here, right? So how do you diagnose a hepatocellular cancer or an hepatic adenoma? Biopsy or a triple phase CT scan? How do you diagnose them? Almost every cancer in and around with liver is diagnosed by radiology only. Biopsy role is demeaning a lot because of many other complications. Very difficult to access the tissue and there's lots of complication of hemorrhage there. So you have to know about, as an undergraduate, you have to know about the radiology of liver cancers, not a biopsy, fine? I'm not saying you should completely ignore it. Maybe when you go to postgraduate, I need to know about it. Undergraduate time, we'll try to push it down a little bit because practically it's not helpful, that's all. Yeah, perfect. Okay, next question. Same, 30 seconds, then we'll discuss. I hope the font is visible. Okay. Anyone wants to add to whatever Akshat said? Do you have a difference of opinion or do you accept his answer? Can be. Great. I thought some of you will make a mistake. You're not making a mistake. Good for you. Fine, I'll look at the question. We'll read through the question. It's a 45-year-old person presents with episode of hemoptysis. As a puffiness of face, pedal edema and systolic hypertension. A chest radiograph shows a 5 cm perihilar mass in the right lung. Normal electrolytes and a transbronchial biopsy was done, right? And shows in the image. I'll look at the image. So looking at the image, it's a lung cancer. In lung, we have very, very few cancers, right? Squamous, adeno, small cell. So what is this diagnosis? Like you guys said, it's a classical small cell carcinoma of lung, right? I don't have glands here. There's no keratin pearl here. So it's undoubtedly in small cell carcinoma of lung, right? So when I have a small cell cancer of lung, tell me what all paraneoplastic syndrome comes to your mind. I am not asking you one important thing, anything which comes to your mind, any paraneoplastic syndrome. Any paraneoplastic syndrome? SAADH, great. So for most of you, SAADH came first, right? Cushing's also possible, but obviously I'm going to think of an SAADH first. Hypercalcemia will be seen in squamous cell carcinoma, right? So SADH is one of the important one. Cushing's is also one of the important one. But like you said, SADH is bit more common than Cushing's, obviously. Fine. But you guys didn't write as antidiuretic hormone. That is not the answer which you gave. Most of you gave option B. The simple reason being, SADH is commonly seen in small cell carcinoma, obviously. But my patient is having puffiness of face, pedal edema, systemic hypertension, as well as there is one more classical finding, has normal electrolyte values, right? So everything is in favor of Cushing syndrome. This patient particularly is suffering from Cushing syndrome. So what is going to be positive is corticotrophin, right? If I don't have the history here, I'm going to prefer an antidiuretic hormone only. Since the history is such of a Cushing syndrome, I cannot expect an ADH secretion be elevated here, right? So there's no history, only small cell carcinoma image, and I'm going to ask paraneoplastic syndrome. I want you to go for your SADH. Otherwise, in this patient, it's going to be Cushing syndrome. Fine. So can we discuss few things about your paraneoplastic syndrome? I'm just going to tell you the paraneoplastic syndrome. I want you to comment on which cancers we'll see them. Fine. I'll start with an easier one. Let's start with hypercalcemia. You can answer anything, not just lung, any tumor in the body. Hypercalcemia, which paraneoplastic syndrome comes to your mind? Obviously, squamous cell carcinoma of lung is one of the important thing. Anything else strikes apart from your squamous cell carcinoma of lung for hypercalcemia? I can see them in breast cancer. I can see them in renal cancer as well, right? So it's not just squamous cell carcinoma of lung. That's definitely one of the common one. When you have hypercalcemia, you can see in squamous cell carcinoma of lung. You can see in breast cancer and your renal cancer as well. Fine. Okay. Cushing's. Cushing's, tell me any one cancer apart from small cell carcinoma of lung. I am sure you know about small cell carcinoma of lung. Cushing's, apart from small cell carcinoma, pancreatic cancer, right? Keep this in mind. Pancreatic cancer can also cause Cushing syndrome. Fine. Okay. Great. So the other one, SAADH. These are the three ones which you're contemplating here, right? SAADH. Tell me any other cancer apart from your small cell carcinoma of lung again for SAADH. Any cancer. You must have read about SAADH in your medicine as well. SAADH can also be seen in intracranial neoplasms. Few gliomas can have SAADH, right? So keep that in mind. It's not just your small cell carcinoma. I do have something else as well, right? We'll go to a few more easier ones. Myasthenia gravis. I just want one answer. That should be more than enough. Since these are commoner one, I gave you other options. Rest of the paraneoplastic syndrome, one answer should be more than enough for us. Myasthenia gravis. What cancer, what tumor comes to your mind? That's a classical one. Myasthenia gravis. Yeah, and also one more thing. Pure red cell aplasia, right? Both of them are common in thymomas. Both pure red cell aplasia and myasthenia gravis are common in thymomas. The opposite of pure red cell aplasia, when I take polycythemia vera, where do you see polycythemia vera? At least one. There are 2, 3. At least one I want. Polycythemia vera. RCC, obviously. Hepatocellular carcinoma, other one. And the third one is cerebellar hemangioblastomas. Fine. If you remember RCC alone, that should be more than enough, right? RCC, hepatocellular carcinoma, cerebellar hemangioblastomas as well. Fine. In all these conditions, I'm going to see polycythemia vera as one of the important things. Fine. I'm going to ask two questions. I'm having a patient with lots of superficial thrombus, venous thrombus. What is the syndrome with this history, and which all tumors you will see this? Superficial thrombophlebitis. What's the syndrome and which tumors you will see superficial thrombophlebitis? I am sure you know the syndrome. The classical syndrome is your Trossier syndrome, right? It's a Trossier syndrome. Where do you see? Yeah, you can see them in pancreas. You can see them in lung. You can see them in GI cancer, right? There is an old question which has been rotating for a long time, where the answer was only pancreas, right? It's not just pancreas. It's seen in lung cancer. It's seen in GI cancer. Many conditions, right? Okay, Stewart-Treves syndrome. Riju has given us one more important syndrome to discuss. Where do you see Stewart-Treves syndrome, and what is Stewart-Treves syndrome? It's not thrombophlebitis. You're right in saying it is breast cancer, but what is that? What disease is that? It happens especially after axillary lymph node dissection. That's not a paraneoplastic condition. There's a complication. It's your lymphangioma or angiosarcoma, right? Angiosarcoma of the limb due to chronic lymphedema is in Stewart-Treves syndrome, right? That's not your Troisier syndrome, fine? Okay, great. All these will be the answer. The older question of pancreatic cancer should be removed. If the question repeats, it should be all of them, fine? Okay, let's see. Again, one more question, 30 seconds. I want everyone to write the answer. Let's see. Answer? It's a simple, straightforward one. Right, see? It's a very simple one. All of you mostly will give the right answer, right? It's a 45-year-old person presenting with a reddish nodule in the foot, and the biopsy shows a poorly demarcated region, fibroblast and endothelial-like cells lining the vascular spaces, similar lesions in the lymph node and liver as well, and HHV8 was positive in this patient, right? So what is the diagnosis here? What lesion are we talking about? Perfect. I'm talking about a Kaposi sarcoma, right? And Kaposi sarcoma, one of the things which is going to predispose to Kaposi sarcoma, at least in this option, is option A. Obviously, acquired immunodeficiency, HIV retropositivity AIDS is going to predispose to a Kaposi sarcoma, right? So we'll read something close to Kaposi. Kaposi is an important thing. You have to pick up Kaposi in a real life, if at all, if you happen to see them. First thing, when I say Kaposi sarcoma, it's a very, very basic question. I hope you don't make a mistake in this. Is it a benign lesion or a malignant lesion? Kaposi sarcoma. It's benign or malignant? Or is it neither of both? If you want to say it's neither of both also, it's fine with me. Kaposi is, and I'll answer the Clink. Just give me a second. Kaposi is an intermediate neoplasm, right? Kaposi is not malignant. Kaposi is not benign. Kaposi is an intermediate degree of malignancy, right? The reason why we have kept them as intermediate neoplasms, vascular tumors are divided like that: benign, intermediate, and malignant. Okay, am I right in saying that Kaposi sarcomas will regress when I treat my immunocompromised HIV, or when I remove immunosuppression? It will, right? A cancer will not regress like that. Since Kaposi sarcoma regresses when the immunity of the patient increases, so it's kept as an intermediate grade neoplasm, fine? Second thing, so when you take Kaposi sarcomas, there are few predisposing factors. The one Kaposi sarcoma is called as an endemic variant. You know, endemic, it's a virus, it's going to be more common in Africa, right? The second thing, when I can have elderly or a very, very young person, extremes of age group, where the amount of immunity is very, very less. Again, opportunistic infection can come often. They can have a Kaposi sarcoma, right? And we have transplant associated. When a patient is going to undergo any transplant, solid organ or a hematopoietic transplant, undoubtedly there will be immunosuppression done to prevent rejection, right? That also will predispose. The last one is your HIV related. If you see the second, third, and fourth, the common denominator is reduced immunity. So reduced immunity is the problem. Once there's a reduced immunity, you're going to have your HHV8 infection. It's like a commensal, that's all. So HHV8 will cause Kaposi sarcoma, right? We'll see whatever they Clink asked for. Do you know any other lesion which HHV8 can cause apart from Kaposi sarcoma? There are few things which you have to know, which has come in the exam as well. It can cause a lesion in the lymph node. What is that lesion? In the lymph node, we have a disease. What is that? it can cause Castleman's disease, right? And like Tanish said, it can cause primary effusion lymphomas, right? Okay, both your single system and multi-system might be related to HHV8, but yes, like you said, multi-system Castleman disease is more commonly associated with HHV8, fine. Okay, and also obviously Kaposi sarcomas. At least these three you should be able to know in regards with HHV8 related lesions, right? So let's take about Kaposi sarcoma alone. So what's going to happen in Kaposi sarcoma, how it causes cancer, because the way a virus causes cancer came in your last NEET exam in relation with which of the virus will get integrated into the human genome or not, right? So what Kaposi sarcoma virus does is it releases a viral analog like VEGF. The virus has an analog of an VEGF protein. So obviously VEGF is going to be vascular endothelial growth factor. At the same time, this virus, once it goes and affects my endothelium, it will cause inflammation as well. So whenever there's an inflammation, am I right in saying that normally also VEGF will be elevated because for your granulation tissue formation, I need neoangiogenesis, right? So this viral analog causes your VEGF elevation, and also there's a viral analog protein which is going to mimic my cyclin D1. I also have a cyclin D1 analog. So both of them, once you have cyclin D1, it will make sure it will cross the cell cycle G1S phase easily, right? Both of them, there's going to be an increase in your proliferation, which causes your Kaposi sarcoma. There are two things. One is VEGF due to inflammation and the viral protein. Other one is cyclin D1, which helps me to go through my G1 to S phase gate in the cell cycle. So there will be an increased proliferation, right? So Kaposi, the most common location of Kaposi is skin and subcutis. If you've seen the movie Philadelphia, I'm sure you can relate all the clinical features of Kaposi. Be purplish to brown patches, or it has three stages: patches, plaques, and nodules. When you have these three stages, it's going to be Kaposi sarcoma only, fine. So if I see in Kaposi sarcoma, on a microscopy, like you saw in the question, you'll have lots of spindle-shaped endothelial-like cells. There's one more classical finding as well. Kaposi sarcoma also will have the IHC positivity, right? The IHC is very, very important for me because there are very close biopsy mimics called as bacillary angiomatosis. The IHC here is they are positive for CD31, they are positive for HHV8. HHV8 positivity is more important because bacillary angiomatosis will not have HHV8 positivity. Now I'm going to ask you one more leading question here, because there's a very close differential diagnosis for Kaposi sarcoma, both clinically as well as based on microscopy. So tell me, what is the organism which causes bacillary angiomatosis? There's a classical organism. What organism causes bacillary angiomatosis? Bartonella henselae, right? Perfect. So again, one more leading question. So what stain or what marker you will do to identify bacillary angiomatosis? What stain or marker you will do to identify bacillary angiomatosis? They won't be positive for HHV8, obviously. I'm going to do one silver stain, right? Bartonella comes under spirochetes, right? They are very, very, very tiny ones, right? They are very, very tiny ones, tiny stains. Silver stain will be positive. See, 31 will be positive for the endothelium. That's why I said that these are very close differential diagnosis. 31 is going to be positive for both Kaposi and bacillary angiomatosis. That's not going to help me to diagnose it's Kaposi or bacillary angiomatosis. Kaposi sarcoma will be positive for HHV8. That is more important for me. Bacillary angiomatosis will be negative for HHV8. Yeah, it's a trypanosome. It's going to be positive for your silver stain because the trypanosome it's a very slender organism, right? All these slender organisms will be positive for a silver stain. Kaposi will not have that positivity because it's virus, fine. Okay, so this is important for me to differentiate your bacillary angiomatosis from a Kaposi sarcoma, fine. Great. Okay, that's a good question. Just look at the question. Hopefully you'll get the right answer. 30 seconds or 45 seconds. Anyone wants to start the thing? Okay, A. Akshit has gone with A. It's a very good question. Hopefully you will. Okay, Surya has gone with D. Rijo has gone with D. Clink has gone with A again. Okay, I'll just concentrate on whatever is required for us here. See, we'll read through the question. It's a 66-year-old person with no major previous illness, has been feeling increasingly tired, so and so, right? Not required for me much. Lab finding gave hemoglobin of 11.3, hematocrit of 33.8, platelet of 2 lakhs, fine, WBC count of 64,000. So definitely this is one which is going to be elevated, right? So immunophenotyping of the lymphocytes has been done, and this is a flow cytometry image, right? So flow cytometry image says, assuming the dominant population is clonal, right? I'm having two things here. So tell me which is dominant population here, green or red? Which is dominant population, green or red? I have two things here. Which you think is dominant? Because if you know that, my answer is very, very simple. Obviously, the red is the dominant population, right? So obviously here, the red is the dominant population. So the question says that the dominant population is clonal. When I say clonal, that is obviously neoplastic. Whenever the term clonal comes into the question, that's the neoplastic population, right? So here, red is neoplastic population. So now I know what is the cancer cell. The red is the cancer cell, right? So if you know the red is cancer cell, you know, I'm sure you know how to interpret a flow cytometry. Now looking at this image, tell me what is this red cell positive for? There are two markers here, CD19 and CD4. What do you think they are positive for? Sorry, I think it's hidden. CD4 or CD19? What do you think is the red population positive for? The red population is obviously positive for CD4, right? It's in this axis, so it's going to be CD4 positive and CD19 negative. Perfect. So now I know the answer. It's a CD4 positive tumor. If it is CD4 positive, obviously, like Clink has been saying, that it's a T cell marker, right? So my question is about a T cell lymphoma or a T cell leukemia. It's from blood, so I'm going to have a T cell leukemia, right? So now anyone wants to rephrase the answer? Is it still Epstein-Barr virus? It's not, right? So one of the things which can predispose to a T cell leukemia lymphoma and adult T cell leukemia lymphoma is your human T cell lymphotrophic virus, HTLV1. Epstein-Barr would have been the answer if it is an B cell lesion, because most of the Epstein-Barr virus will involve the B cells only. Epstein-Barr will not be involved with T cell at all, right? It's going to be B cell lymphoma, Hodgkin's, non-Hodgkin's, many different subtypes, fine. Epstein-Barr virus will involve the B cells only. Again, there was one more question based on this. The route of entry, Epstein-Barr virus enters the B cell via one particular thing, one particular receptor. It has a name, it has a very specific name. What is the name of the receptor? Epstein-Barr virus enters via CD21, right? CD21 or CR2, right? It enters via CD21 or CR2 receptor. That's CD21. That's one of the important MCQ. Hopefully, if it comes, you should be able to answer. Fine. HIV is not going to cause your T cell leukemia lymphoma. HIV again might predispose to your CNS lymphomas, DLBCL. That's again a B cell lymphoma. Fine. Okay. Right. Fine. Just one question. After this question, we'll call it a day today. Let's see. It's a very simple one. I hope you will write the correct answer. 30 seconds. Yes, flower cells are seen in HTLV. Now the flower cells will look like this. They are actually deeply indented cells. The clover leaf shaped cells are your flower cells, right? Okay, that's a simple one, right? Most of all of you are correct here. It's a 68-year-old person. See, age is a very important clue. When I'm going to talk about a mesothelioma, you always have to remember it should be at least in the 6th or the 7th decade. It will not come before that, right? Complaints of 4 months history of discomfort malaise. X-ray shows a pleural effusion. Patient dies, and this is lung as an autopsy. So if you look at this, this, whatever I'm shading in the black color, is actually the lung parenchyma. So what has happened here is the amount of mesothelium, the pleural mesothelium, which is very, very thick, right? So here it's a pleural based lesion. It's not a lung cancer. It's a pleural based lesion which is compressing the lung, which has caused all the discomfort, the chest discomfort and everything. Fine. So which of the following environmental thing is associated with pleural lesion? So in other words, which of the following causes mesothelioma? If you have to see a patient of mesothelioma in real life or anything related to mesothelioma and MCQ, has to go with asbestos. Asbestos is the only one thing which is going to predispose to a case of mesothelioma. Do remember that. I'm sure you know that as well. Again, a very repeated question. I want everyone to answer here just to reiterate that we know that correctly, right? The most common cancer in a patient with asbestos exposure, mesothelioma or a lung adenocarcinoma. It's undoubtedly an lung adenocarcinoma, right? It's not a mesothelioma, it's undoubtedly a lung adenocarcinoma. Please don't make a mistake in that. Fine. Okay, I think we'll just finish this alone. Just a last question and then we'll call it a day. It's an interesting question. You might miss it if you read superficially. Please read completely and then write tell the answer. Sure, देख लेंगे. I suppose you mean bilateral contracted kidneys. Answer. Okay, B. B again. B again. D. I am not sure why most of you are inclined towards B. Can you tell me the rationale behind it? I'll read the question here. It's fine. A 60-year-old person, ulcerated, encrusted, infiltrating lesion in the sun-exposed area, the dorsal lesion. It's in squamous cell carcinoma, right? Which of the following will increase the metastatic potential of the neoplasm by upregulation of which of the following gene, right? So the question is about metastatic potential. It's not about the primary lesion. It's about the metastatic potential and obviously upregulation, right? I'm sure all of you here will know the first step of metastasis, downregulation of E-cadherin. E-cadherin loss is one of the first step. It's not about the upregulation of E-cadherin, right? It's a downregulation of E-cadherin, right? So at the same time, the plasminogen activator will be upregulated. Plasminogen activator, collagenases, everything, because this helps to destroy the stroma. When it helps to destroy stroma, that obviously will help the spread of squamous cell carcinoma, right? So plasminogen activator, urokinases, collagenases, all of them will be upregulated, which helps in the metastasis. If it's E-cadherin, if the question asks about downregulated, like what I said, I'm going to go with E-cadherin. Since it's upregulation, it is this. I'm not sure why you called it desmin. Desmin is a marker for muscle tissue, striated muscle tissue. There is kind of no role in your squamous cell carcinoma, right? Actin, I do accept, because actin is required in your epithelial mesenchymal transition. Actin might be upregulated in metastatic potential, but not desmin. And if you've gone with epithelial mesenchymal transition and told desmin, it will not be desmin. Actin will be upregulated in your epithelial mesenchymal transition. Fine, because they become your actin and vimentin will be upregulated in your epithelial mesenchymal transition. Fine, okay, fine. That's for today. If you're talking about a bilateral contracted kidney, right? Whenever you have something of a bilateral contracted kidney, I'm going to think of only one thing. It's bilateral involvement. So it should be a local disease or a systemic disease. Anything involving bilaterally should be local or systemic. It has to be systemic involvement only, right? Only when it's systemic involvement, bilaterally equal amount both of them will be involved, right? So first the foremost thing is it's a contracted kidney. The kidney is becoming small. When the kidney is becoming small, am I right in saying that there should be some amount of atrophy or loss of kidney parenchyma? Yes, it's becoming smaller in size, which means it has undergone atrophy. There has been some amount of atrophy and it is causing a problem, right? So if a kidney has to undergo atrophy, the only way a kidney will die here is based off ischemia. So ischemia is the most common cause of atrophy, or ischemia is most common cause of infarction. So chronically, like you said, a very low grade ischemia happens because the patient is not presenting also, right? Slowly ischemia over a long period of time. I'm having a vessel here. This has a perfectly normal lumen. The only possibility I can have a slow ischemia is when the vessel lumen becomes smaller. If the renal artery becomes smaller, I'll have a problem. There'll be symptoms involved. So the vessel what I'm talking about is arteriole. If the arteriole is going to get affected or an capillary is going to get affected, that will cause destruction of the kidney, which will cause ischemia, which will cause destruction or atrophy, but it will be very minute atrophy, so it will go unnoticed. If it is going to be renal artery, it will be noticed. So atherosclerosis is not the answer. So the lumen has to become smaller over a long period of time. So any case of an chronic glomerulonephritis, I can have an destruction of the capillary. Slowly glomerulus destroys. I had a superb kidney like this. Okay, one day tiny destruction happened because that glomerulus went away. After a month, one more glomerulus. After next time, here. The same thing with arteriole. Again, tiny areas goes away. So it goes unnoticed. At the end, I'll have a smaller kidney. That's the pathogens of your bilateral contracted kidney. Two diseases. One is chronic glomerulonephritis. Second thing involving arteriole. Arteriole is nothing but your resistance vessels. So any case of systemic hypertension, long-standing benign hypertension also will cause a chronic contracted kidney. Fine. These two are practically important. There are a few more differential diagnoses as well that might not be important for a practicing person. Fine. Okay. I hope that's clear, Deklinga. Any other doubts? FSGS, I will keep it as an end stage, right? FSGS need not be contracted. It will be destroyed glomerulus, so it will present to me early. So I will not let them to destroy the kidney over the period of time, because FSGS is completely sclerosed. Right? Yeah, the size will be reduced, but again, bilaterality for FSGS is a bit an unlikely thing. FSGS can happen unilateral as well. Fine. Okay. Chronic pyelonephritis, again, it will not be symmetric. When you think about chronic pyelonephritis, it will also cause destruction of the kidney. It will be asymmetric. Again, if it's a chronic pyelonephritis, it need not always become small. I can have a scar like this. I can have a scar like this. Asymmetric scarring. One kidney might be preferentially affected than the others. Fine. Okay. I hope that's clear. Fine. Great. So we'll call it a day. And by 7 p.m., be in the Unacademy app. We'll be discussing the liver images, and if possible, we'll go to your gallbladder and your pancreas as well. We will start the class by 7 p.m. with few MCQs in the GIT, intestine, what we saw on the previous day, and hopefully we'll be completing all the Robbins image sessions before your NEET exam. Okay. If there are no more doubts, we'll call it a day. Thank you for your time. See you. Bye-bye.